Now this next topic is malaria. We all very well know what are the different causes of parasites which are leading to malaria. Mosquitoes are the major culprits which leads to malaria. Malaria is an important tropical disease, most important protozoal disease in humans, affecting 350 to 500 million patients annually with 1 million deaths. It is commonly seen in Madhya Pradesh, UP, Orissa, Jharkhand, Gujarat, West Bengal, Assam, Maharashtra, Karnataka, etc. Etiology, as we very well know, that transmission malaria spreads to human beings by bite of female Anopheles mosquito. Its rare transmission is by blood transmission, transplacental, which is also called vertical transmission. Even congenital malaria is known, and very rarely it can be transmitted through contaminated needles. This is the female Anopheles mosquito, which because of the bite of this human beings, they get malaria. The vector which there are almost 400 species of Anopheles mosquitoes identified. Common one is Culicifaces, which is active in the rural area, and Stephensii, which is active in the urban area. Environment transmissions influenced by the climate between 20 to 30 degree centigrade and 60% humidity. This is the most vulnerable period during which the transmissions are more common, and these mosquitoes, they breed in stagnant water, so that is the breeding site for them. The other causes, other etiologies which leads to more of transmission are genetics patients, but there are certain things which can also prevent the patients from getting malaria. One is genetics. Patients of thalassemia, sickle cell disease, G6PD deficiency, ovelocytosis might be protected against malaria. Also, patients with Duffy and A and B antigen resist malaria. Cause is poor penetration of erythrocytes by merozoites, diminished growth of the parasite inside such RBCs, and rapid clearance of such RBCs by reticuloendothelial system. This is the life cycle of malarial parasite. The mosquito bites the patient, and then the sporozoites, they enter the liver. They are called schizons. Inside the liver, they multiply inside the hepatocytes. Then the hepatocyte ruptures, and multiple the merozoites are released inside the blood. These merozoites, they enter the RBCs, and inside the RBCs, ring forms are formed. Now inside the RBCs, again these merozoites, they multiply, and then that RBC ruptures, and again those parasites, they enter the outside. They come outside the RBCs and they enter the blood. They may infect the new RBCs, or some of them may get mature into male and female gametocytes. And at this site, if another mosquito bites, these male and female gametocytes will enter the mosquito, and then the sexual cycle inside the gut of the female Anopheles mosquito will take place. So this is the life cycle which is repeated. Mosquito bites, sporozoites, infective stage of the parasite, it enters, inoculated in the subcutaneous capillaries and disappear from the blood later. They enter the hepatocytes and multiply asexually. Thousands of merozoites form inside the hepatocytes. So these hepatocytes then finally rupture. They release the merozoites into the blood, and merozoites invade the RBCs through receptors. Inside the RBCs, they are called trophozoites, and they appear as ring forms. Merozoites multiply by repeated nuclear division, and RBCs rupture. These release daughter merozoites. They again infect the new RBCs, and some parasites differentiate into sexual form, and microgametes and macrogametes are formed. If mosquito bites, the gametocytes are ingested. They fuse to form zygotes inside the stomach of the mosquito. Oocyst is formed, it bursts, and sporozoites come in the saliva. Mosquito is ready to infect the other patients. Immunity is not lifelong. These are the certain facts in malaria. In endemic areas, antitoxic immunity develops. It is called premunation, that is protection against severity but not illness. Due to less cytokine production, the severity will be less, but patient will be still infected. Rarely seen, malaria is rarely seen in newborn due to fetal hemoglobin. In protein energy malnutrition, there is decreased chance of malaria, and HIV, there is increased risk of malaria. There are other certain facts: breastfeeding, transplacental antibodies, fetal hemoglobin, thalassemia, sickle cell disease, they decrease the growth of parasite, and this leads to decreased chances of malaria in such patients. Only erythrocytic stage causes pathogenesis. When infected erythrocytes rupture, cytokines like interleukins and tumor necrosis factor are produced largely. They are responsible for fever and other problems. These cytokines are the major things which are responsible for the fever and all the complications occurring in malaria. They decrease erythropoiesis, these cytokines. They decrease gluconeogenesis, and therefore patient lands up into hypoglycemia. Even platelet dysfunction is because of these cytokines and because of these parasites. And there is dysfunction of the platelets, and they also cause cytoadherence. Usually there are three things which are pathophysiological things which are seen in malaria. One is cytoadherence, means these they adhere to the endothelial cells of the capillaries. They form rosette formation, and there is clearance from the peripheral vessels. This is the erythrocytic stage. Cytoadherence, sequestration, and rosetting are the main phenomena observed, especially in P. falciparum malaria. Cytoadherence, infected RBCs become sticky and adhere to the capillary endothelium. Sequestration, disappearance of infected RBCs from microcirculation to capillaries of important organs like brain, heart, liver, GIT, kidneys, etc. are blocking. Rosetting, infected RBCs also adhere to healthy RBCs, blocking the capillaries. All these three cause impaired circulation of various organs. This is the typical knob-like RBC which is already infected, containing the parasite. Fever with rigorous clinical features include all the three stages: myalgia, malaise, irritability, nausea, vomiting, diarrhea, pallor, slight jaundice. These are the classical clinical features seen in all malaria types. On examination, there is pallor, fever, tachycardia, jaundice, liver and spleen are palpable. Types of severe complicated malaria. One is cerebral malaria, when the CNS is affected and patient, that is typically because of falciparum malaria, which is the most common one which leads to cerebral malaria. Second is algid malaria, black water fever, severe anemia, renal failure, and hepatitis. These are the common complications seen, and majority of them are because of falciparum malaria. Mostly, cerebral malaria is mostly due to P. falciparum, very rarely due to P. vivax. Signs and symptoms are fever, severe pallor, jaundice, seizures, coma, decerebrate posturing, and rarely papillary. Usually, we do not find any cranial nerve palsies or meningeal signs. All the features are mostly due to blockage of capillaries and venues by RBCs containing parasites. Cerebral blood flow increased to meet the metabolic demands of the parasites. This increases the intracranial pressure, but there is no cerebral edema. Therefore, there is no role of mannitol or steroids in cases of cerebral malaria. Also, this is associated with hypoglycemia. And if there is hypoglycemia, this worsens the patient's condition, and this is bad. And usually there is mortality, which is added on because of hypoglycemia. Hemiparesis, these are the common sequelae in cerebral malaria, that is hemiparesis, ataxia, cortical blindness, mental retardation is very rare, but can occur if the child is very small and got falciparum malaria, aphasia, which all these contributes to less than 10% of patients. Differential diagnosis in a case of cerebral malaria, we may confuse with meningitis, encephalitis, head injury, or tetanus. Now, second complication of malaria is algid malaria, characterized by circulatory failure and shock. Usually occurs in P. falciparum malaria in non-immune children. That is, it is the first attack of malaria by falciparum malaria. In such cases, algid malaria may be found. Almost all the complications, complicated malarias or complications in malaria usually are seen in the first attack of malaria. As the malaria becomes a chronic one, the complications will subside, but patient will have anemia. Patient has cold extremities, hypotension due to hypovolemia, and also there is gram-negative bacteremia, which will worsen the condition. Black water fever, it is characterized by sudden and massive intravascular hemolysis and passage of cola-colored urine due to hemoglobin urea. In severe cases, renal failure may develop. Black water fever may occur in the following three situations. One, G6PD deficiency, patients given oxidant drugs regardless of they have malaria or not. Secondly, G6PD deficient patients have malaria and also receive quinine, will have black water fever. Thirdly, even if the patient is G6PD, normal G6PD, quinine itself may lead to black water fever. Hypoglycemia occurs in 30% of patients due to cytokine-induced suppression of gluconeogenesis, and therefore there is increased glucose consumption. So it's a rule always we give antimalarials in 10% dextrose to avoid hypoglycemia, further by the antimalarial drugs also. Hypoglycemia itself is one of the complications because of anaerobic glycolysis, because of infection, because of malarial parasite, quinine-induced stimulation of insulin secretion. These all lead to hypoglycemia. Now, congenital malaria can be caused by all the four species. It occurs in babies of non-immune pregnant women. Abortions, stillbirths, premature birth, IUGR, these are the common things which are seen in children. Clinical features: fever, irritability. If a child is having congenital malaria, he may have fever, irritability, failure to thrive, pallor, jaundice, and hepatosplenomegaly. It can also confuse with other TORCH group of infections, but we have to rule out congenital malaria. That's the more common one. Chronic complication in cases of malaria are tropical splenomegaly, a big massive spleen with anemia, stunted growth, failure to thrive, and patient is having pancytopenia because of this huge spleen is classical for tropical splenomegaly, and the most common cause of a big spleen is chronic malaria. The other chronic complication, a rare one, is nephrotic syndrome, and very, very rare is endemic Burkitt's lymphoma. Apart from this, even history of gallstones is very common in cases of chronic malaria. Now, how to diagnose malaria? Complete blood count, ESR, random blood sugar, serum electrolytes, Vidal test. Because a patient is having high-grade fever, chills, rigors, body ache, headache, so that can also occur in typhoid fever. Blood group should be done because we have to give blood transfusion, so we should know what is the blood group. Urine, stool, CSF, blood gas analysis, coagulation indices, liver function test, and X-ray chest. These are the basic investigations to be done to rule out other things and to rule out other causes of similar means high-grade fever, which is rigors anemia. Test specific for malaria is the peripheral smear, which is the gold standard. Both thick and thin smears should be prepared. Quantitative Buffy coat malarial parasites contain DNA which takes up acridine orange and it's seen on microscopy. Other thing to confirm malaria is antigen detection, PCR, and serology for anti-malarial antibodies. So these are all the things, these are all the tests which can be done to detect malaria. Prevention is always better than cure, so we should take care that the mosquitoes should not breed in the stagnant waters, and therefore this DDT spraying should be done wherever we find stagnant water, which is there where the breeding of mosquitoes is taking place. Now, treatment of malaria, we should always divide the treatment into three parts: the general management of the patient, treatment specific for malaria, that is anti-malarial drugs, and treatment of complications. So if we divide this, it will be very easy to treat malaria. The first thing is the general measures to be taken: assessment of ABC, that is airway, breathing, circulation, if the patient is coming in shock or patient is coming into all the complications like cerebral malaria. We have to treat hypoglycemia and dyselectrolytemia because that will worsen the condition if we do not take care of this. Do the assessment of coma, maintain hydration of the patient, management of unconscious patient like catheterizing the patient, take care of the bladder and bowel, put a nasogastric tube, take care of the eyes, take care of the breathing, take care if the patient is on ventilator, we have to take the ventilatory care. So this is regarding the management of unconscious patient. Antibiotics to be added if we are thinking of superadded or secondary infections, or patient is landing up into bacteremia, gram negative, we have to add on with antibiotics. Anticonvulsants usually are given if the patient is having cerebral malaria or is having convulsions because of this, because of electrolyte imbalance or because of hypoglycemia. We have to treat accordingly, and we can also add on anticonvulsants. Blood transfusion, if the obviously patient has anemia because of RBC lysis, and therefore blood transfusion is to be given after doing cross match. Dialysis is only needed if the patient is landing up into renal failure. We also have to take care of the raised intracranial tension. So we have to treat accordingly. The second management is the basic, that is the management of malaria, uncomplicated malaria and complicated malaria. Chloroquine sensitive, we have to give chloroquine 10 milligram per kg stat, followed by 5 mg per kg after 6, 24 and 48 hours. And if the patient is chloroquine resistant, or if the patient is vomiting chloroquine, means he is having gastritis, then we can add on pyrimethamine and sulfadoxine combination single dose, or quinine 10 mg per kg TDS, or we can give artesunate based combination therapy. In malaria, in falciparum malaria, we can give artesunate daily for 3 days plus sulfadoxine or sulfalyl pyrimethamine combination like drugs. We can also give mefloquine, or we can give artesunate or artemether for 6 continuous days. The other drugs which can be tried in malaria are quinine. Is a wonderful drug, but we have to give it under cardiac monitoring. Should be done because it can lead to arrhythmias. Quinine to be given in 20 milligram per kg loading dose, IV in 5 or 10%, dextrose 10 ml per kg in 4 hours, then 10 milligram per kg maintenance dose every 8 hourly for total 7 to 8 days. Or we can give artesunate 2.5 mg IV loading dose followed by 1.2 milligram per kg at 12 hours, then once daily for 6 days. We can also try with artemether or clindamycin if the patient is not responding to the routine line of management. Chemoprophylaxis. Chloroquine, till now there is no anti-malarial vaccine, so chloroquine itself is said to be a malarial vaccine. At present, chloroquine 5 mg per kg weekly for 3 months, or mefloquine weekly, or doxycycline to those patients who are entering the endemic area, or those who are coming to India from abroad. We can start this 1 month before and give them after they leave India also, so that they won't get malaria. Relapses are prevented by giving primaquine 0.25 mg per kg per day for 14 days in cases of Vivax malaria, while in falciparum we can give a single dose of 0.75 mg per kg. Malaria, anti-malarial drugs themselves are called as traveler's vaccine for malaria. So this is regarding malaria. Just remember all the complications, majority of them are because of falciparum malaria, and the parasite which is responsible, the mosquito which is responsible is the female Anopheles mosquito. And we have to take care of the hemoglobin dropping down. We have to take care of the hypoglycemia. We have to take care of the CNS status and the renal failure. All the complications are usually because of the cytokine release which is occurring in because of RBC lysis. And we should remember that the gold standard to diagnose malaria is the thick and the thin smear, and the anti-malarial drugs should be started as soon as possible to get the results. Thank you very much.